Moving on to the second part of Chapter 5, having spent the first portion of this chapter discussing the pathomechanisms of maladaptive, should I say, heart-lung interactions, which can occur in patients with underlying obstructive lung disease, with the removal of positive pressure, and how this can exacerbate or emphasize negative cardiovascular physiology, particularly in patients with underlying cardiac disease. We're now going to move on to the patient with underlying cardiac disease and how this can certainly feed back and impair pulmonary mechanics and certainly thoracic mechanics, which will then again feed back into this loop and lead to this vicious cycle of badness leading to badness, which you can get when you're extubating patients with bad cardiopulmonary disease. So we kind of spent this whole pathway coming down to this LVD, which is a poor abbreviation, generic abbreviation for left ventricular dysfunction, and essentially right ventricular dysfunction, left ventricular dysfunction. What I mean by that is basically either a lower cardiac output for a higher filling pressure or a higher filling pressure for the same cardiac output, which essentially defines a downward and to the right shift of the cardiac response curve, or the Frank-Starling curve. And so this ultimately co-conspires to elevate your left atrial pressure, with higher filling pressures of the left heart required for a given forward flow. The left atrial pressure will elevate, and as I'm sure you can begin to admire, is that will then lead back and impair pulmonary mechanics quite greatly. And it does so through primarily interstitial and alveolar edema, and I'm going to go through some of the mechanisms here. So just a brief review of excessive pulmonary lung water. This is kind of cool studies done maybe 30 years ago where they tried to look at the sequence of events that led to frank alveolar edema. And what they found was if you elevated left atrial pressure, first you'd have pulmonary congestion, and this was just essentially an increase in your intravascular volume in the lungs. You get recruitment and dilation of the pulmonary vascular beds. You get this cephalization on the chest x-ray where blood flow, which is preferential to the bases because of gravity, is then distributed to the upper lung fields, and you have vascular engorgement of the upper lung zones. But in these patients with true pulmonary congestion, there still hasn't been any extravasation of lung water. It's just plump vessels. And then if this is worsened, if your left atrial pressure is worsened, and there's a decrement in the gradient of flow from the pulmonary vascular beds to the left atrium, it progresses from pulmonary congestion to bronchovascular interstitial edema. And bronchovascular interstitial edema is essentially interstitial edema of the bronchovascular bundles. So the bronchovascular bundles, as you may remember from anatomy, lead back up to the hilum of the chest, and it's essentially traces back the airways back to the mediastinum. And the interstitial space here is more exposed to pleural pressure, so actually the interstitial space here tends to be lower than the interstitial space surrounding the alveoli. And this creates kind of a sump function where lymphatic drainage is actually facilitated from the alveolar space to the bronchovascular interstitial space, and it draws lymphatic drainage back up to the hilum and back to the heart. So this preferential pressure gradient actually preferentially retains interstitial edema in the bronchovascular space first. And it has been estimated in people that up to 500 cc's of fluid can actually be kind of quote-unquote hidden in the bronchovascular interstitial space as edema progresses. And then as these mechanisms are overwhelmed with worsening left ventricular dysfunction, higher left ventricular filling pressure, this Bronchovascular interstitial space can no longer act as a buffer zone, and then you start getting interstitial edema around the alveolus. And then, as you can imagine, once the fluid breaks through the alveolar epithelium, it can then flood the alveolus itself and lead to frank alveolar edema. So this is kind of my silly cartoon of a bronchovascular bundle. So you sort of imagine these branching and branching and branching all the way from the hilum down to the alveoli, or in reverse if you want to think of it that way. But this is an airway here, and it's traveling with a pulmonary artery or pulmonary arteriole. So this is your bronchial, this is your pulmonary arteriole, and normally there's this potential interstitial space between the two of them. And what they found was that if you flooded poor dogs or increased their left atrial pressure and let them progress to this bronchovascular interstitial edema, and then immediately did freeze fracture techniques on the lung tissue, and then look at it under the microscope immediately, or on the electron micrograph immediately, what you see is you kind of actually can really physically see this interstitial space now open up, and so that this is actually all full of fluid, and this is the bronchovascular interstitial space here that I'm highlighting here. And what you may not be able to appreciate is that this is actually starting to collapse the airway here compared to here, and actually collapse the arteriole. So what does this bronchovascular interstitial edema do? Well, it actually increases airways resistance and increases pulmonary vascular resistance. And this is probably the etiology for so-called cardiac wheeze. That not all that wheezes is asthma, and it may actually be extrinsic compression from fluid. So you have to use your imagination here. This is another one of my cartoons, but this is kind of a cartoon of an electron micrograph of a alveolar blood vessel, essentially. This is the pulmonary capillary endothelium that I'm tracing out here. So these are the endothelial cells. This is a red blood cell traversing that space, so they go in single file. And then this kind of army green is the alveolar epithelium. And then this space between the two here, this is the alveolar interstitium. So you can imagine that an oxygen molecule, if this is an alveolar space out here, and this is actually there tends to be two kinds of alveolar interstitium. It's not really important for this discussion, but this is the thick side and this is the thin side. But if this is an alveolar space here and this is an alveolar space out here, well, then oxygen has to go through the alveolar epithelium, through the alveolar interstitium, through the capillary endothelium, and then move through the capillary itself, through the cell membrane of the red blood cell, and then to hemoglobin. So I think I am gonna highlight these here. This army green, or this light green, is the alveolar epithelium. So these are the type 1 pneumocytes that you may have read about. This is the capillary endothelium here, as I talked about. And then these are alveolar spaces here. And again, this space here, this is the alveolar interstitial space there. And that's actually, as I mentioned, once you overcome that 500 cc's or so that you can kind of hide in the bronchovascular interstitium that I showed you on the last slide, if that becomes overwhelmed and then there's an impairment to flow from the alveolar interstitial space, well, then you start getting alveolar interstitial edema. And so what is the effect of that? Well, there's multiple effects. First of all, this interstitial edema particularly actually increases pulmonary vascular resistance and therefore your pulmonary arterial outflow impedance. Well, how does it do that? Well, we'll go back to this cartoon that I introduced in Chapter 2, and I'm going to introduce maybe some physiology that you may not have heard of, and that is West Zone 4 physiology. So I think we're all fairly familiar with Zone 1, Zone 2, and Zone 3. And Zone 1, again, is when your alveolar pressure supersedes pulmonary arterial, capillary, and venous pressure. Zone 2 physiology is when alveolar pressure supersedes pulmonary venous pressure. Zone 3 physiology occurs when alveolar pressure actually supersedes none of them, so pulmonary arterial, capillary, and venous pressure are all greater than alveolar pressure. And we talked a little bit about what happens in these zones when you have an increase in transpulmonary pressure or lung volume that you would get if you take a breath in or put a patient on mechanical ventilation. Remember, both spontaneous ventilation and mechanical ventilation both increase transpulmonary pressure and therefore lung volume. And it tends to collapse zone 1 and zone 2 beds, and so these arrows which represent flow are diminished. And that leads to this change in your pulmonary venous return curve, and you can review Chapter 2 if you're interested in why. And then an increase in transpulmonary pressure increases venous return from zone 3, so this augmented arrow results in an increase in pulmonary venous return to the left atrium as transpulmonary pressure increases. But interestingly, if you increase lung volume or increase transpulmonary pressure in zone 4 physiology, you actually tend to decrease pulmonary vascular resistance. And the reason that occurs in zone 4 is because in zone 4 occurs when the interstitial alveolar edema, so this is sort of as you're increasing lung volume. Sorry, I've cartooned that out here. If you increase transpulmonary pressure or lung volume, you actually sort of improve flow here, which tends to also track this pulmonary venous return curve. And what happens is this interstitial edema, because this is in the bronchovascular bundle, as I mentioned 3 or 4 slides ago, this tends to affect mostly extra-alveolar vessels. And so when the interstitial edema supersedes the pressure in the pulmonary arteriole, you actually start to get collapse of this vessel, and they become tortuous, and they collapse on each other. And therefore, as you increase transpulmonary pressure or lung volume, you actually kind of unwind these vessels, and you reverse this physiology where the interstitial edema collapses the pulmonary arterial, supersedes pulmonary arterial pressure, and therefore you mitigate this collapsing effect as you increase lung volume in these patients. But all this being said, this interstitial edema, this is sort of a long way of me explaining that this interstitial edema certainly has real effects on the pulmonary vascular bed, and certainly independent of simply an increase in wedge pressure. I think that when patients come in heart failure or fluid overload or elevated wedge pressure, we just sort of think as an increase in the wedge pressure, therefore there's an increase in the downstream pressure, and therefore pulmonary arterial pressure will increase. But remember that the greatest determinant of vascular resistance in any bed is the cross-sectional diameter of the entire vascular bed at a given level. So the surface area of the alveoli is roughly the size of a tennis court if you were to lay it out all flat. And so I'm certain that the pulmonary vascular bed is probably somewhat similar. So if you're going to increase pulmonary vascular resistance, you have to invoke an explanation that really impairs the resistance throughout all of these vessels. And that's probably in pulmonary congestion, certainly, and interstitial edema. A lot of it has to do with this West Zone 4 physiology where bronchovascular interstitial edema begins to impair and collapse pulmonary arterioles. So that will feed back into this and spiral around, worsen right ventricular dysfunction, left ventricular dysfunction. Interstitial edema and alveolar edema additionally can feed back and impair thoracic compliance, which again will, with impaired thoracic compliance, you'll have lower intrathoracic pressures on inspiration, greater intrathoracic pressures on expiration, increase your work of breathing, and can then feed back into this, cycle back around. So how does excess lung water impair pulmonary compliance? So I pose this question: during which phase of excess lung water does pulmonary compliance decrease? Is it congestion, where you just have plump vessels? Is it the bronchovascular interstitial edema, which we just talked about with West Zone 4 physiology? Is it alveolar interstitial edema, or is it alveolar edema when the actual alveoli themselves are flooded? And of course the answer is all of them. And this has been studied in humans using kind of cool technologies for maybe 20 years ago or so. But what's certainly been found is that, the references for these studies are all in the written volume. But what's been found is that the largest drop, by far and away the largest drop in pulmonary compliance, occurs with frank alveolar edema. That is, the alveoli themselves are flooded with fluid. And the reason that is, I'm going to provide a mathematical description that some authors gave, and this is going to come on this slide here, and I just want to let you know this is very nerdy. Some of you may turn out. You probably just skip the slide if you don't like words and numbers. But what has been found is that the formation of alveolar edema kind of occurs in this all or none effect. That is, the alveolus is totally flooded or not flooded. And there isn't really a good explanation as to why that is, but it's certainly it's what's seen. And what is thought to occur is that the edema, the alveolar edema, when the alveolus is flooded with fluid, significantly reduces clearly the radius of the alveolus. And it also impairs pulmonary surfactant activity. If you're interested in surfactant, well, I discuss it in the written portion of Chapter 1 and talk a little bit about it in my online lecture in Chapter 1. But I think you can appreciate that with flooding of the alveolus, you're going to decrease the radius of the alveolus through fluid and also of the airways through bubble froth, and you're going to impair surfactant activity. And so if you imagine the volume of a alveolus as being a little sphere, that's 4/3 pi r cubed, you may remember, and that the pressure of this little sphere, this little bubble, can be described by Laplace's law, and that is 2 times the tension, 2 times the wall tension over the radius of the bubble describes the transmural pressure that must be applied to maintain that little sphere open. And again, this tension, this is surface tension, so this is going to be greatly affected by surfactant activity. And then you were to say, well, compliance is the change in volume or the change in pressure, and then you kind of combine these. You get this compliance as being very heavily sensitive to changes in radius of the sphere, and of the sphere, and also compliance being related to the tension, so the surface tension. So if you're to decrease the surface tension, say by, if you were to increase the surface tension by impairing surfactant activity, you would tend to decrease compliance. But similarly, if you were to decrease the radius of the alveolus, you'd have a much greater impact on the compliance of the whole lung. And so that's what I'm saying here, decreasing the radius from flooding of the alveolus and alveolar bubble froth and increasing the surface tension by decreasing surfactant activity will very drastically reduce pulmonary compliance. And likewise, as I've already really explained in a previous slide, interstitial and alveolar edema will lead to increased airways resistance. And this is essentially congested lung physiology. That is to say, if you have left ventricular dysfunction, a high wedge pressure, especially if you have comorbid underlying cardiac disease, impaired inotropic response, valvulopathy like mitral regurg, certainly tachydysrhythmia, which will all serve to elevate your left ventricular filling pressure for a given forward flow. Elevated left atrial pressures, if you then run into interstitial and alveolar edema, well, then you're going to worsen pulmonary arterial outflow impedance, but also worsen pulmonary mechanics. Then you're going to increase airways resistance, lower pulmonary and thoracic compliance, which then results in wild changes in intrathoracic pressure, which then further worsen ventricular loading conditions, ventricular outflow impedance. And this could potentially lead you into this death spiral, not necessarily death spiral, that sounds kind of scary, but certainly a very abrupt failure to liberate from mechanical ventilation. So as I mentioned in the previous slide, this is the bronchial, this is your pulmonary arterial, this is the potential inner space that becomes full, and this really, in the written volume I have the references for this, but there's the papers and the authors that have looked at this, there's really kind of cool pictures that describe this quite nicely, that with alveolar and interstitial edema, there's an increase in airways resistance, and this has also been measured in humans, that in patients who come in fluid overloaded and in pulmonary edema on chest x-ray, and you are able to get them to cooperate enough to do pulmonary function testing, and you measure their airway conductance or resistance, and you measure their total thoracic compliance, and you can also measure pulmonary compliance as well. If you were to drop an esophageal balloon and measure the transpulmonary pressure for a change in lung volume, you can measure your pulmonary compliance. And what's been found in these patients is that indeed they have an increase in airways resistance, which explains cardiac wheeze, and they have a drop in pulmonary compliance, which can result in rapid shallow breathing, hypercapnia, and very low intrathoracic pressures on inspiration during spontaneous ventilation, and high intrathoracic pressures during expiration, which, as we saw in previous slides, can really impair biventricular loading conditions and can lead to worsening of this physiology. So this talk is my way of introducing and sort of reiterating some of the physiologies that we've talked in the previous chapters, and how this can be used to explain some of the patients who are kind of tenuous in terms of their underlying cardiac disease, their underlying pulmonary disease, and why they can look somewhat good or even good enough to liberate from mechanical ventilation. And when you pull that tube, they do quite poorly quite quickly. And again, this is really a way of me saying that when you're thinking, this is a very messy way of me saying that when you're thinking of extubating a patient, you got to make sure that their pulmonary mechanics are pristine, so their dynamic work of breathing or their airways resistance is minimized. Okay, secretions, COPD, asthma, interstitial edema. You've got to make sure that their thoracic compliance is optimized. You know, they don't have a big belly full of ascites pushing up on their chest wall, which is impairing thoracic compliance, or they don't have a lung full of water that's impairing their thoracic compliance. And you've got to make sure that their biventricular loading conditions are really optimized. They're not fluid overloaded. And this explains why some patients, cannot be liberated from mechanical ventilation. You just diurese them for a few days and they get better. You give them some bronchodilators for a few days and they get better. You use some pulmonary clearance techniques and you get out the secretions and they can then extubate. So keep all of these things in mind when you are getting ready to liberate a patient from mechanical ventilation. So just this last slide, in terms of this interstitial edema, which can increase airways resistance, and dog models, for what it's worth, not that many of you are looking after dogs in the intensive care unit, but this is just to remind me that there may be, it may not just be purely a mechanical effect, but certainly that this pathophysiology, and again, this may be particular to dogs, as they tend to be very vagal animals. They're salivating all the time, and there's secretions everywhere. For those of you dog lovers out there may know that this may be something unique to dogs, but in humans there certainly may be a neurohumoral component to increased airways resistance as well. So again, that's it for Chapter 5. This is my website, which you're on. I mean, it's hard for me to imagine how you could be watching this if you're not on my website, but I guess it's possible. Thank you for coming. Tell all your friends. I hope that I'm helping you. Have a wonderful day.